Hello friends, today we are going to learn about management of DKA, which is an acute complication of diabetes. We will review the presentation, evaluation and management of DKA in pediatric population. However, the basic concept remains same in adult population as well, so the topic is equally important for UG as well as medicine PG students. So friends, whenever we encounter a DKA patient, we have so many questions in our mind like what fluids to start, which guidelines to follow, when and how to start insulin in these patients, how to monitor these patients, and how to manage complications in these patients. But let's not get bothered by these questions. If you follow proper guidelines, then the results are very rewarding with very good outcomes. So friends, let's get started with the management of DKA. So how do we define diabetic ketoacidosis? But before that, you should know that diabetic ketoacidosis is a life-threatening condition which is a preventable but serious complication of type 1 diabetes mellitus. The mortality rates are much higher in developing countries up to the tune of 10%. However, the mortality rate in the Western world have gone down to less than 1%. We should remember that cerebral edema, the most feared complication of diabetic ketoacidosis, the incidence has not changed despite changes in fluid guidelines over a period of time. You may see that overall the incidence of DKA is on a rise. As the diabetes is increasing, so are the cases of DKA. However, the case fatality rate has gone down significantly. If we talk about definition of diabetic ketoacidosis, so it can be easily remembered by the acronym DKA. So you need diabetes, that is blood sugar of more than 200 milligram per deciliter. Then you need ketonemia, that is blood beta hydroxybutyrate level of more than equal to 3 millimole per liter. And then acidosis defined as venous pH of less than 7.3. There are two major guidelines which we follow. One is BSPD, that is British Society for Pediatric Endocrinology and Diabetes, and the other is ISPAD guideline, that is International Society for Pediatric and Adolescent Diabetes. There is just one difference between the two definitions. Whereas BSPD guidelines defines a cutoff of bicarbonate less than 15 to define acidosis. On the other hand, ISPAD guidelines say bicarbonate less than 18. That's the only difference. Otherwise, you need D, K and A to prove a diagnosis of diabetic ketoacidosis. One thing which you must remember is that it is a ketonemia and not ketonuria, which is a part of DKA definition. However, we commonly use urine ketones as a proxy marker for ketonemia. The problem is that urine dipstick measures acetoacetate and not beta hydroxybutyrate, which is the main ketone body. Also, since beta hydroxybutyrate get converted to acetoacetate, therefore ketonuria may persist despite resolution of ketonemia. So urine dipstick is a good test for diagnosing DKA, but it is not a good test for follow-up of these patients. So how does a DKA patient present? They usually present to you with a triad of dehydration or shock, along with acidotic or fast breathing, and sometimes they may have coma or altered sensorium. But you must remember that in isolation, these presentations can be present in other diseases as well. Like dehydration or shock can be there in a patient who is suffering from diarrhea or septicemia. Similarly, fast breathing can be caused by acute respiratory problems like pneumonia or bronchiolitis. Then diarrhea, septicemia, RTA, certain inborn error of metabolism can also lead to fast breathing. Coma can result from acute CNS infection like meningoencephalitis and metabolic disorders like hypoglycemia. Similar to clinical triad, there is a biochemical presentation which is also a part of DKA definition. So you need to have all these three components of hyperglycemia, acidosis and ketosis. But remember, in isolation, these lab parameters can be found in other disorders as well. Like hyperglycemia can be there in stress hyperglycemia, acidosis can be there in lactic acidosis, RTA, uremia or inborn error of metabolism. Then ketosis can be there in a case of recurrent vomiting or prolonged starvation, and certain inborn error of metabolism can also lead to ketosis. Clinical signs of dehydration may not be very evident in a case of DK that you must remember, because these patients have intracellular dehydration in the early course, and later there is extracellular dehydration as well. Typically, these patients, despite being dehydrated, their urine output is maintained or they are passing high amount of urine. So if you encounter a patient who looks dehydrated but the mother says the child is passing good amount of urine or the just passed urine in the ER, then you must consider DK as your prime diagnosis. All hospitalized patients, whenever a patient is hospitalized for the management of DK, you have to assume some sort of dehydration in these patients, although the dehydration may not be clinically evident. Okay, so there are certain clinical fallacies when you manage a case of DK. These patients have vomiting without loose stools. They are breathless, but there are no lung signs. There is no wheezing, no crepitations. Lung is absolutely clear. They are dehydrated, but they are constantly voiding urine. There is shock, but these patients are not oliguric or anuric, and mother will complain that child is losing weight despite having a very good appetite. There are lab fallacies as well. These patients have high TLC without infection, which could be because of hemoconcentration or stress. Hyponatremia is a spurious finding in a case of diabetic ketoacidosis. We will talk about it later also. Then these patients may have hyperkalemia despite having a low total body potassium. It is because there is relative insulin deficiency. And then we have already discussed that ketone urea may persist even when the ketonemia has resolved. So what are the goals of therapy when you manage a case of DK? So obviously, the priorities are to correct dehydration and acidosis first, to reverse ketosis. You have to gradually correct their hyperosmolar state. You have to obviously correct their blood sugars. And finally, you have to monitor these patients for development of complications, especially brain edema. And then if you find any precipitating cause like sepsis or pneumonia, you have to treat that underlying cause. So we start with fluid therapy in DK. Fluid therapy in DK consists of three prongs. It is the first, the bolus or the resuscitative fluid therapy. Then you correct their deficit, and you have to obviously give them maintenance fluid therapy. So previously we used to try Milwaukee protocol, but of late more evidence-based guidelines have come up. So commonly used guidelines are ISPAD and the BSPD guideline. So the ISPAD guideline says that if the patient of DK comes to you in a shocked state, the patient is in shock, then you give 20 ml per kg as quickly as possible. If the patient is non-shock, then you give 10 ml per kg of fluid bolus over 20 to 30 minutes. Then you correct their deficit over 24 to 48 hours, right? In a severe DK, you have to assume a 10% deficit. Previously in Milwaukee protocol, we used to assume 8.5% deficit in DK patient, but now we assume 10% deficit in both ISPAD and BSPD guideline. The BSPD guideline differs from ISPAD is that once the patient come to you in shock state, you give 10 ml per kg bolus over 15 minutes. So they have specified the duration also that it has to be given over 15 minutes and not as quickly as possible. And then they further say that if the shock is not resolved by then you can repeat these boluses and up to 4 boluses can be given. So over up to 40 ml per kg can be given to these patients over 1 hour. If the patient is non-shock, then you can give 10 ml per kg over 30 minutes. So again, they are more specific than ISPAD, which says over 20 to 30 minutes. Then another difference is that they clearly mention that deficit is to be corrected over 48 hours, and they have not given a range that in some patients you can correct it over 24 hours to 48 hours, but they specifically say that it has to be corrected over 48 hours. Now, which protocol is better? Whether you give fluid rapidly in 24 hours or you give fluid in 48 hours. So there is this landmark trial which provides an answer to this question. So what they did in this trial, they divide the patient in 4 groups. In one group, they give fast normal saline correction, that is over 24 hours. Then in the other group, they give slow normal saline correction. In the third group, they give fast half normal saline N by 2 correction. And in the fourth group, they give slow half normal saline correction. So more than 1300 episodes of DK were observed and they primarily look for the development of complication in form of decline in their mental status. And the end result was that there is actually no difference in terms of outcome or secondary complication. So it doesn't matter whether you use normal saline or half normal saline, whether you give correction over 24 hours or 48 hours. It is the monitoring which saves the patient, and it is the dynamic nature of illness, and that along with that the dynamic change in the treatment which is required, which will make ultimate difference in the outcome. Right. So how do we begin with our management? Like any other emergency, it is to be managed with management of ABC first. So you ensure that the airway is patent. If the patient is hypoxemic or is having fast breathing, you provide them 100% oxygen by face mask. You make sure that you put two large IV bore cannula. You withdraw your required samples and you begin with your fluid resuscitation. So how do we begin fluid resuscitation? As per BSPD guideline, if the patient is shocked, we start with 10 ml per kg bolus and we will give it over 15 minutes. If the patient does not respond to this bolus, then we will repeat the bolus, and up to 4 times we will keep on repeating this bolus. Once we are done with our fluid therapy, then we will start these patients on their deficit plus maintenance therapy. So let us understand this with an help of example. You have to remember this, that fluid given for resuscitation, that is the keyword, resuscitation, are not subtracted from ongoing maintenance fluid. This will be further clear when we look at our examples. So let us run with this example. A 60 kilogram 15-year-old girl with a pH of 6.9 who was shocked at presentation and received 30 ml per kg of normal saline for resuscitation. Now these boluses will not be subtracted because this patient was shocked and you give fluid for resuscitation. So you will calculate just the deficit. So 10% deficit because the patient is in severe decay. So 10% deficit will come out to be 6000 ml, which will be replaced over 48 hours as per BSPD guideline. And maintenance fluid you will calculate as per the holiday cigar method. So total fluid will be your deficit plus maintenance and no subtraction will be done. Simultaneously, when you will look at the other example where a patient of 20 kg comes to us with a pH of 7.15, so around moderate decay, where you assume 5% dehydration, and he also received a 10 ml per kg bolus as a part of initial fluid therapy, but this patient is not in shock and you are not giving initial bolus to resuscitate him. Yes, here the bolus is a part of initial fluid management. So when you calculate fluid in this patient as per 5% deficit, which will come out to be 1000 ml, then you will subtract this initial bolus. So that is the difference. When the patient is shocked and you give fluid to resuscitate them, that fluid will not be deducted. However, if you give fluid as part of initial fluid management, which is given as a slow bolus over 30 minutes, then that fluid needs to be deducted. That's it. What kind of fluid you should use? We commonly prefer isotonic fluid as it is easily available to us. But as the NEGM trial also suggests, you can use either N by 2 or even plasma light. But just a clinical hint in this kind of situations, N by 2 without dextrose is usually not available. What is available in our wards is N by 2 in 5% dextrose, right? So if you have to make N by 2, then you have to dissolve NS in equal amount of distilled water, right? Then as and when the blood sugars go down, you are keep on adding dextrose, right? So you will add 5% dextrose when the blood sugar will fall to 250 to 300 milligram per deciliter. Then if it is further falls to 150 milligram per deciliter, then you will increase your dextrose concentration to 10%. You can go up to 12.5%. But remember, as a first response to low blood sugar, you do not decrease your insulin. Insulin will continue at same rate because it is the insulinopenia which is responsible for everything, right? So you do not decrease your insulin as a first response, rather you increase your dextrose concentration. And if the blood sugar are still falling despite getting a sugar despite starting a blood sugar of 12.5% dextrose, then you may start decreasing your insulin level. You have to keep a watch on electrolytes in these patients. You have to ensure that all fluids contain 40 millimole per liter of potassium chloride unless there is an evidence of renal failure or there is already hyperkalemia. You should also remember that this hypokalemia can occur even after 48 hours of starting DKA treatment or stopping DKA treatment. There is always depletion of total body potassium in these patients because of polyuria and because they are thin built, they have low muscle mass. So the overall total body potassium may be even low, normal or even high, and you should anticipate the fall in potassium level once you start your insulin therapy. Another important ion which you have to take care in these patients is sodium. So there are several factors in DKA which will cause apparent lowering of the plasma sodium level. So the total body sodium may be depleted because these patients are having diuresis. So some amount of sodium may lose with this diuresis. But secondly, or more importantly, the increased concentration of extracellular glucose will pull the water into the intravascular compartment, leading to a situation of pseudo hyponatremia. So there is pseudo hyponatremia, so you have to calculate the corrected sodium. So there is formula for that, and I will make a separate video and how to apply this formula and what are the easier method to calculate the corrected sodium. So if you are getting a sodium of 125 in a patient of say having a blood sugar of 600 milligram per deciliter, it will actually be somewhere around 133, 135 and not 125, right? Okay, so insulin is the mainstay of therapy. Insulin is the specific therapy which we initiate in a case of DK. But remember that intravenous insulin infusion you have to begin after your initial fluid therapy and not immediately. There is no role of subcutaneous insulin when you are managing a case of severe DK. However, mild to moderate DK can be managed with subcutaneous insulin as well. Usual starting dose is 0.05 to zero point 0.1 international unit per kg per hour. Again, there are studies which say that there is no difference in ultimate outcome of the patient whether you start with this lower dose of 0.05 or you begin with a dose of zero point 0.1, right? Now the guidelines says that if the patient is already on subcutaneous insulin pump therapy, then you have to stop the pump when you are starting them on IV insulin. In the children who are on long acting insulin, say glargine, then you have to keep continue this at the usual dose and time. So giving insulin infusion is an art itself, right? We know that insulin get binds to your plastic tubing, especially PVC line, right? So there is adsorption of insulin to the infusion sets, and your syringes and tubings should be flushed with insulin prior to attachment. And this adsorption is higher when you use lower flow rate. So if you are managing a case of DK, say 10 kg child or 20 kg child, we are using a flow rate of say 1 ml per hour or 0.5 ml per hour, then the adsorption becomes even more important, right? So you have to instruct your nursing staff to load the syringes and prime the tubings when you begin your fluid therapy. And it is not like that once you have managed the fluid therapy patient with your fluid therapy, and after 2 hours you are telling the sister that yes nurse, now we need insulin as well. No, already when you have begin your fluid therapy, tell them to load the syringe so that it gets enough prime, right? uh, Also one point you have to remember that the potassium should be normal, because we already discussed that potassium is bound to fall. There will be intracellular movement of the potassium once you start insulin infusion. Also, when you are giving insulin to the patient, make sure that you use a transparent dressing, right? So that you know that there is no leakage or seepage from the line. It is better. However, if you have to use some splints in these patients, then make sure that you are using a three-way so that you can see that there is no leakage in the line. These are the practical tips when you are giving insulin infusion. Now, when to stop IV insulin? Stop is, I would say, is not a correct word. Correct word should be the switch over. So we don't stop IV insulin, we switch over IV insulin with subcutaneous insulin. So there are certain criteria. When the blood ketone is less than 1 millimole per liter, when the anion gaps have become normalized, the pH is more than 7.3 or bicarbonate is more than 15, and the patient is clinically stable, his sensorium is normal. Remember that blood sugar and ketonuria, for the obvious reason, are not a criteria to make this switch over. Now, how do we make this switch over? We have to make an overlap with short or rapid acting insulin. You plan 6 hourly subcutaneous insulin pre-meal. Now, don't be too meticulous in your insulin prescription and don't write specific timing like 6 p.m., 9 p.m. because it is better to write pre-meal, because the children may uh, vary in their when they take their meals. So don't be too meticulous in writing that prescription. Just write pre-meal. Then you have to titrate it according to blood glucose. via sliding scale. I will make a separate video on how to make a sliding scale. Then calculations are according to their weight, and you can start with, if the patient is a known case of diabetes, then you can very well start with the pre-hospital insulin dose. Now this is one of the most feared complication of diabetes, and the mortality rates are up to 10 to 25%. In the developing nation, the mortality rates are even up to 50%. So if the patient has developed cerebral edema, then you can say that half the battle has already been lost. There are two hypotheses. Earlier it was thought that it is because of the rapid fluid correction that the cerebral edema develops, but now we know that there are vasogenic edema and cytotoxic edema as well responsible for cerebral edema. You have to have a high index of suspicion to detect it early so that treatment can be started, and we treat it with hypertonic saline or mannitol. Again, there are studies which say that no agent is better than the other. So if you have detected cerebral edema, treat it with whatever is available. This is an interesting graph again from a study published in NEJM. So if you see in this graph, this is the timeline of developing cerebral edema. You see that certain patients have developed cerebral edema at the start, even before you have begun the treatment. So they come with cerebral edema. They come with features of cerebral edema in the emergency itself. Another point to take from this graph is that majority of the patient, almost 2/3 of them, will develop cerebral edema in the initial 6 hours. So your initial fluid therapy is very, very important. And then almost 90% patient develop cerebral edema in the first 12 hours of therapy. So that if the patient has not developed cerebral edema within the first 12 hours of therapy, then he is unlikely to do so in future. The monitoring is of utmost importance in a case of DKA. Why we have to monitor? We have to monitor them for the signs of recovery and for development of complication, especially brain edema. And what do we need to monitor? We have to monitor their vital signs as well as lab parameters. No patient of diabetic ketoacidosis can be managed unless you have an institutional DKA monitoring chart. This DKA monitoring chart is nothing but all the lab parameters and clinical parameters, their urine output, your medications, what insulin dose is going, and how the lab parameters are improving over the time. Right? So this chart will tell you whether you are going in the right direction or not. And what do we mean by going in the right direction? So your serum sodium and your serum bicarbonate level should increase with your appropriate therapy, while your blood sugar, your potassium, your anion gap, your blood ketones, your blood urea and creatinine levels, and your TLC should decrease. If all this is happening, it means that you are going in the right direction. However, despite giving them right therapy, some patient may not improve. And there can be reasons for that. If the patient is not improving, if there is persistent acidosis, then you should revisit your treatment always. You should look whether you have calculated the right dose, whether your fluid resuscitation was enough, whether you have calculated your fluids in a right manner. Even if still the patient is not improving, you should consider underlying sepsis, whether the patient is having hyperchloremic acidosis because you have infused too much of normal saline in them, or is there renal failure has set up in this patient, or there is drug overdose. Invariably, the DK patients admitted in PICU end up receiving antibiotics, but there are certain indications where you should give antibiotic to these patients, and not all patients require antibiotic. So if a DK patient has fever, if the shock is refractory to your fluid boluses, or you find obvious focus of infection like UTI or skin boils, or if there is persistent metabolic acidosis or lactic acidosis, then you must administer antibiotics in these patients. So if I have to summarize, if a patient of diabetic ketoacidosis comes to you in the emergency and you have to make a diagnosis of DKA, then you always begin, after correcting your ABC, you begin with your initial fluid resuscitation, right? You take out the important blood samples which include an ABG. Initially an ABG is required. In the future, in the later course of the disease, a venous blood gas is good enough. You take out the sample for serum electrolytes, RBS and KFTs. You also measure your urine ketone level through urine dipstick. Once you are done with your initial fluid resuscitation, through preferably a second line, you start your patient on insulin drip. Then once your insulin drip is started, the patient blood sugar will start improving. and then you will keep on adding more dextrose to your fluid therapy. You also keep on adding potassium as per the patient requirement, because potassium is bound to fall with your insulin therapy, and you keep on increasing dextrose until the patient maintain the sugar in the targeted blood sugar range, and only when you have reached a 12.5% dextrose, then you can start decreasing your insulin, right? And there has to be continuous clinical and lab monitoring of these patients. So the key messages of this presentation is that early recognition and high degree of suspicion is required to not only diagnose DKA but also their complication. Volume resuscitation is given only in shock patient. You have to begin your fluid replacement therapy first, and once you are done with that, then you begin your IV insulin therapy. Monitoring is of utmost important, and monitoring is the key in management of DKA patient. You have to monitor them not only for clinical signs, not only for complication, but lab parameters at frequent interval. You must have noticed that I have not even talked about bicarbonate in this presentation, because bicarbonate is not at all needed. We have all managed patients of DKA of 6.8 pH, 6.7 pH. They are very well managed with your fluid therapy and insulin therapy, and within 10 to 12 hours of therapy, these patients are sitting on their bed and asking for food, right? And prevention is the only way to reduce mortality of DKA. So you must counsel your diabetic patient so as to what to do, how they have to use sliding scale when their blood sugars are getting high. So with that, thank you very much.